Thank you for listening to the P-Pod from the Somerset Safeguarding Children Partnership. Due to the nature of this podcast, themes relating to the abuse and neglect of children are discussed. Therefore, listener discretion is advised and the content unsuitable for children.
Welcome to the P-Pod.
Welcome back to the P-Pod, the partnership podcast from the Somerset Safeguarding Children Partnership. Now, the Domestic Abuse Act in 2021 brought about a number of really significant changes relating to the safeguarding of children. Some of the most well-known changes, including the definition of what domestic abuse actually involves, and that expanding to include controlling and coercive behaviour, and the very important fact that children who witness domestic abuse are classed as victims of that abuse. Now, one thing that isn't so widely known is about the additional knock-on effect that this legislation had on the Serious Crime Act of 2015, which was amended to introduce two new sections, sections 75A and B, which creates a whole new and specific criminal offence on the topic of non-fatal strangulation and suffocation. So the question is for today, what does this have to do with safeguarding children? Well, it follows concerns that perpetrators were avoiding punishment, as the Act often leaves no visible injuries, making it hard to prosecute and take action under existing offences such as ABH. But additionally, studies have shown that victims are 7 times more likely to be murdered by their partner if there has been non-fatal strangulation beforehand. And in domestic abuse, up to 44% of victims have reported being strangled. Homicide reviews show that victims of non-strangulation are 7 times more likely to be killed at a later date. So today we have Dr. Louise.Newbury, the named doctor for child safeguarding, who is passionate about this subject and keen to talk with us today. So Lou, welcome along to the P-Pod. Great to have you joining us today.
Hi, Steve. Thanks for having me. It's great to be here.
No, thank you. And I know this is an area that you're really passionate about. So before we get into the subject of today's episode, could you just kind of explain what your role is and sort of your involvement in the Safeguarding Children Partnership and wider?
Yeah, so I'm the named doctor for safeguarding children for Somerset Foundation Trust. It's a really big trust now. We've got 2 acute trust hospitals. We've got all the MIUs, CAMs, and several other services within our trust. So it's a big old unit, Somerset Foundation Trust. So I am the medical advisor to the team. We've got a big team of safeguarding professionals, and I'm the medical advisor for that team, both for the doctors and nurses that work in the trust, but also for all the for the multi-agency working that we do within the partnership as well. So I provide medical advice for that too. And I've come from a background of general paediatrics. I was a general paediatrician for a number of years. And then I went off for a couple of years to work in sexual offences. And that's where I first became interested in strangulation as part of that work down in Devon and Cornwall. And then I've come back to Somerset for this role.
Well, it's great to have you here, because I know you're a wealth of knowledge and experience, which brings a lot to the working of the partnership and safeguarding children. So thanks for joining us here. And before we kind of really get into the subject, could you explain, kind of laying the baseline really of what is non-fatal strangulation and why is it such a significant concern? I guess both in the context of safeguarding children and protecting adults as well.
So that is really interesting. So strangulation. Really, the definition of strangulation is application of pressure to the neck. And that's different from suffocation. The two parts are actually separated in the Act, suffocation and strangulation. So suffocation involves reducing or emitting air to the person or oxygen to the person. But that's different from strangulation, which is specific to the fact that there is pressure to the neck. They can have the same effects. So there is an effect on breathing for both offences. But the other real trouble with strangulation, and the thing that makes me really concerned when I hear that someone's body's been strangled, is the damage and effects on the other structures in the neck. And the neck is such a vital part of the body because it has so many vital structures that, if damaged or if pressure is applied to them, can lead to death and can lead to catastrophic consequences. So it's not just the airway. So there's pressure to the airway, which can result in lack of oxygenation to the brain, but also pressure to the blood vessels. And there's both arteries and veins in the neck. Arteries are thick-walled, veins are much thinner walled. The arteries take the blood flow to the brain, and the arteries bring the blood flow away. If a more minor amount of pressure is applied to the neck, that then affects the blood vessels, the veins, and the jugular vein. The amount of pressure applied to occlude the jugular vein and stop the blood coming away from the brain is about 4 pounds per square inch. The pressure to occlude the carotid artery is much higher, so that's 11 pounds per square inch. So to stop the blood flow going to the brain is 11 pounds per square inch. Whereas to occlude the trachea, so to stop the air going up and down through the windpipe, is 34 pounds per square inch. So the amount of pressure varies as to which structures are affected. So that's just to stop them working. But then the pressure applied, if it more than that again, actually can permanently damage those structures. And the difficulty is, the problem is with the carotid artery is that if you apply a lot of pressure to that, it can then lead to what's called dissection of the artery, and the ballooning of the wall of the artery and the blood flow going to different places and outside the artery, and big blood clot formation. And that leads to stroke. And it's really dangerous. But equally, pressure to the vein causes stagnation, a bit like having a dam in a river. You have blockage of the blood coming away, which eventually backs up and stops the blood coming into the brain, but also, again, increases the stroke risk, but also increases the risk of having a bleed inside your head. So those vessels are so important. If you block either of those, you affect your brain. If you affect your brain long enough, bad enough, you have brain damage, and then you also can die. But that pressure, it sounds, quite abstract. What's 4 pounds per square inch? What's 11 pounds per square inch? What's 34 pounds per square inch? To put it into context, to open a can of Coke, it's 20 pounds per square inch.
Okay.
So you can occlude those blood vessels less than opening the pressure you put to opening a can of Coke. And then an adult male handshake, because, we all know those men that we go and shake hands with and are out, our hand hurts afterwards. I'm sure you have one like that.
There's a bit of a strange dominance thing that goes on sometimes with handshakes. I've got to be honest. It's a bit strange.
There is. Well, the average male handshake is 60 to 80 pounds per square inch. So actually, to occlude your trachea, the windpipe is almost half of what an adult male handshake pressure is. So that pressure is not very high. So you don't need much pressure. And there are some bits, such structures in the brain, which are absolutely devastating if they get affected. And then there's also other structures in the neck. So there's also these areas that affect how the heart works. So there are nodes which control the heart rate. If you apply pressure to those areas, the heart can just stop. And that's what's thought is why some people are killed by strangulation but have no evidence of damage to their neck. And that's because the pressure on these areas in the neck slow down the heart rate to such an extent that the heart just stops beating. And that pressure, we don't know exactly what that pressure is, but it's probably even less than that to occlude the blood vessels. So pressure to the neck is really, really dangerous. And that's why I get really upset when I hear that somebody's had pressure applied to their neck.
You mentioned around legislation and definitions. And sometimes when you sort of see a change to definition, it seems sort of fairly minor. But like you said at the start, it's so important that that definition is correct, because when things get to court, things can be very easily thrown out if it doesn't meet that exact definition, isn't it? And then we're in a very difficult position of kind of sometimes arguing semantics about why something is really important, but it didn't quite fit that. The same as we talked about the expansion of the classification of domestic abuse, including control and coercive behaviour, because up until that point, when you get to court, it's really hard to sort of say, well, actually, this has had a big impact on a victim, even though it doesn't quite fit the current classification, which makes it very difficult. So I think it's really key when you see these changes, just understanding how important they can be sometimes. And like you say, how, as you've already explained, how important this is for people to really understand, which is why we're keen to talk about it today, really.
I think people are quite scared to use the word strangulation. So, first of all, victims of strangulation often don't use the words I've been strangled. They, in my experience, they rarely say I've been strangled. They never say I've been non-fatally strangled.
No.
So the definition for the act is very different from what people tell you, and it's very different from what the words professionals use as well. So children particularly, but adults too, do not say I've been strangled. They say I've been choked. They say I've had something put around my neck. They say my jumper was pulled around my neck. They say he put his hands on my neck. They say he leant on my neck. They say and I'm saying the word he because unfortunately this is a gender-based crime, and overwhelmingly unfortunately the perpetrators are men and victims are usually women, except when you come to children, which is really interesting. So children, the male-female divide in victims is not the same as in adults. There's very little research on children at the moment. It's coming, but it's not there yet. But it looks as if, certainly from my personal practice and from the stats that are coming out so far, the division is much less male to female for victims when they're children. But any victim does not say, I've been strangled. They say all of those other words. And actually, the definition of strangulation is interesting as well, in that there are lots of different modes of strangulation. And that's really interesting too. And depending on the mode, depends on what symptoms and signs we find in victims.
Right.
So, for example, you can have manual strangulation, where one or two hands are placed around the neck. You can have a choke hold, or a sort of a neck hold with the arm, which produces far less symptoms. And actually, that we rarely see signs. We rarely see signs of strangulation in the choke hold version of strangulation. There is ligature. And a ligature isn't necessarily a rope or a cord. It could be a jumper. It could be the neck of a shirt, a school tie we've had. Hanging, of course, which is different again. And there's different pressures and different modes of injury within hanging. And then pressure on the neck from a foot or a knee or a leg. And actually that is as much in the act of and in the definition of non-fatal strangulation for the criminal justice system as is hands around the neck or an arm around the neck.
And that's like we saw with George Floyd over in America, wasn't it? From his murder, from being knelt on his neck.
Yeah. Kneeling is, especially again if it's an adult male, kneeling on the neck can cause considerable amounts of injury.
Just picking up from that, as we talked about in the introduction, often non-fatal strangulation often leaves no visible injury, as you've just mentioned. So with that in mind, are there any sort of common signs or symptoms or indicators of non-fatal strangulation that people should be aware of?
Yeah, so that's really scary. So we do know from adult victims that about 50% of victims have no discernible injury on the outside, which is really scary. So, I've heard time and time again, they've said they've had something put around their neck, but we don't think they've been strangled because they've got no injury that we can see. But actually it is common. Not over 50% have no injury at all.
Because that's what I'm thinking. Because often if somebody sees a bruise somewhere, I'm going to put this in quotation marks, easy or easier to say, something has been committed. There's an injury there. We can see that and we can take action. But when there's no sort of visible bruising or injuries or marks, like I say, it's quite challenging, isn't it?
Yeah, it is much more challenging. But what's particularly challenging is that we know that almost 1 in 50 victims of strangulation have internal injuries.
Right.
And that's the scary bit. So when I'm saying about you can have damage to your arteries, you can have damage to your vein, you can have damage to your windpipe, you can have a fracture of your windpipe. Those are all internal injuries. And you can have all of those with nothing being seen on the outside. So about 1 in 50. What's really interesting is that it goes up considerably to 70% of victims when you've had loss of consciousness. So if you have been rendered unconscious during your strangulation, you've got a 70% chance of having internal injury, which is far higher.
Yeah.
So we've gone from 1 in 50 to 70%.
Yeah.
To 2% to 70%.
Am I right in thinking, from what you've been saying then, that no obvious sort of common immediate kind of signs and indicators? Is that right?
There are some. So common signs of strangulation are, so 50% do have external injuries. So the common things to see are bruising or pinpoint bruising, which are called petechiae. So bruising or petechiae to the neck. And then these little blood spots, petechiae, to the area of drainage of those vessels that are in the neck. So you're going to have them over the face. The face can look a different colour. It can look kind of purple or blue. You can see these little tiny black or purple or red spots over the cheeks, over the eyelids and over the forehead, and also sometimes around the ears as well. So you can have these little pinpoint bruising over those areas. And then you can also have subconjunctival hemorrhage. So you can have the red bits in the white of the eyes, the bleeding into the whites of the eyes as well can happen. And that's all through the lack of drainage of that area. And as we talked to already, that's caused by a lesser pressure than occluding the blood supply to the brain. But if the person is rendered unconscious, that means that they have had either occlusion to the blood vessels supplying blood, the arteries, or to the windpipe, and those things imply a bigger pressure than the blood spots. But as I said, 50% have nothing at all. So for predicting internal injury, what we need to do is know those symptoms that people may have had around the strangulation event. So were they unconscious? Did they have incontinence? So did they wet themselves? Did they poo themselves? Did they have incontinence of feces? Did they have a fit? And have they got loss of memory? So loss of memory implies that they had a lack of oxygen to the brain or lack of blood supply to the brain. And memory is stored in an area of the brain called the hippocampus, and it works quite slowly, the hippocampus. So if you don't get blood supply to it, you lose memories. They may well not say, I was unconscious or I wet myself. They might say, I don't remember what happened. And if they say they don't remember what happened, then it's likely that they have had a reduction in blood supply or oxygen to their brain.
And I guess just going back to your introduction at the start there about your role in that advisory role, I guess a large part of it would be around the emergency departments, I presume, in terms of sort of what they may see coming through the doors.
Yes, I get quite a few calls from ED saying, what should we, we've had somebody who's complained of being strangled, what should we do? And so what we have is a really clear risk assessment for victims of strangulation, which includes things like, have they got any bruising? Have they got any signs of reduced blood supply or reduced blood drainage from that area? And then about the symptoms as well. So were they unconscious? Did they have incontinence? And based on those, we will then potentially scan somebody with a CT angiogram of their neck, and also think about whether they have an MRI or a CT of their brain as well. The angiogram of the neck is to look for those things I was talking about with the blood vessels, where you can have a dissection of the artery, because we know that that's a really high risk for stroke. And also we'll often start these patients on anti-stroke medication before we've even got to scan.
Okay.
Increasingly, this is new guidance over the last couple of years, and this is, we are really keen that these patients, if somebody complains of strangulation, they are seen medically as soon as possible, and we will start them on anti-stroke medication, sometimes just aspirin, but sometimes more advanced anti-stroke medication as soon as they come through the door, depending on their risk. And then we will scan them either neck and brain to look for complications of the strangulation. And that's so important, because in the past only about 5% of strangulation victims have come to medical attention. And so we're really keen that anyone who's complained of having been strangled is medically assessed as soon as possible to prevent those fatal complications, which can happen up to a month afterwards.
Wow.
So you can stroke up to a month after your strangulation. And it's thought that potentially young women who have had strokes, there may be a real unknown number of those who have been strangled, because women don't always say that they've been, don't admit that they have been strangled as part of their domestic violence.
Yeah.
Or don't admit to domestic violence at all, of course.
Yeah. I'm just thinking from what you were just talking about just then, and I think potentially there's a risk with this. Obviously, we get a wide variety of different professionals listening to the P-pod, and I think there's a risk with this potentially that people might be listening to this thinking, okay, well, this is really a medical issue and it's not for us. But I guess from what you've been talking about already, I guess we've got kind of 3 layers to this already. The first layer about listening to victims or potential victims and understanding the language and what they might be telling us, and we talk about professional curiosity a lot of the time. So it's about that sort of curiosity about just exploring that a little bit. So you've got that sort of first layer. Then you've got that kind of second layer of triage, I guess, of asking those questions you've been talking about of, do you remember what happened, or all these kind of things. And then that third layer, which is more of the medical intervention around potentially doing scans and what have you. So I guess for me, one of the kind of key parts of this is that anybody, as you've just been saying, can absolutely play a vital role in those first two aspects in terms of listening to victims and in terms of asking those curious questions and trying to do that kind of initial triage is possibly too strong a word, really, but just trying to understand the context a little bit and then having the alertness to say, okay, this is kind of ticking some boxes, which says there could be quite significant medical risk here, and then potentially sort of referring into the hospital for medical intervention to look at those scans. Would you say that was kind of accurate?
Yeah, definitely. And you've got to remember there's the two things. So there's the fact that there is a stroke risk for any victim of strangulation, and that's really important. And then the second thing is that we know that if you've been strangled, you are 7 times more likely to be murdered. So that, if you hear that somebody has been strangled as part of your professional work, this needs to be taken really seriously, both risk assessment for their long-term health and well-being generally, but also medically, that they are at risk of stroke. And also, you need to deal with it quickly as well. If you hear somebody has been strangled in the previous 24 hours or previous couple of days, this is not something that can be just processed in your normal ways of you think this, for example, if this is a child, this could be part of a pattern of physical abuse. This is not something to sit and have refer for a strategy meeting in a number of days. This needs to be dealt with acutely. This needs to be dealt with on the day. As soon as you hear, this person needs to be referred to police, to children's social care, and to medics for medical assessment. These victims cannot sit around waiting for a multi-professional response in 4 or 5 days' time. This needs to be dealt with now, here, today. And I would suggest if it happens out of hours, it needs to be dealt with an out of hours response as well. But it needs to go right the way through to, also to health professionals. That when we hear that someone has died in their 30s and they're female of a stroke, we need to think, actually, has that person had a post-mortem? Have they had their neck vessels looked at? Because there is a risk that they have had strangulation as part of the causation of their death. So it has to go through. It goes through all the layers of practice.
I just taking us back a little bit, actually, to something you said a moment ago about sort of gender-based violence when we're talking about adults, and often with that we might be thinking about sexual violence as well. And I'm just thinking as you're talking, there's been numerous studies now around modern pornography, and we've talked about that on some of previous episodes, and that's showing that quite significant increase in those trends around sort of domination of women, particularly as part of sexual acts, which often sort of includes choking as a sexual act. Is that something you see coming through in terms of choking, and how does choking, I'm going to again use air quotations that nobody can see here, but how does kind of choking relate to kind of non-fatal strangulation and that kind of risk that we've been talking about?
I'm not 100% sure which way round it is. So is it that there is a rise in choking as part of pornography, that there's then leading to increased choking or strangulation as part of gender-based against sexual assault? Or is it we're just hearing it more and we're more open to hearing about strangulation as part of it, and we're asking the question? And I think if you don't ask the question, you don't know. But we know there's some really interesting stats out from St Mary's, which is the largest centre for seeing victims of sexual assault and rape. And they found that in adults, 1 in 11 women that they were seeing, strangulation was part of that. I say women, actually, some of these were men. So they had, out of over 200 cases that they took they took a certain amount of time. They only had 3 cases where the offender was a female, and 2 cases where they didn't know whether they were female or male. So actually, this is again a male-based offence. But they found that 1 in 11 of their victims that they saw had strangulation as part of their offence, and that's a huge number more than certainly when I was doing the work. I've been working sexual offences on and off for about 15-20 years now, and those numbers are far higher than when I started, definitely. But again, I'm not sure that I ever asked the question specifically. But then what's really interesting is that it goes up to 1 in 5 if this offence was by a partner or an ex-partner. So is it that domestic violence is increasing, or is it that this is part of sexual crimes from pornography? And I would suggest that the fact that it's higher from a partner or ex-partner is actually that domestic violence is increasing. And also part of that we're asking the question more often.
No, it's interesting, isn't it? And I think just picking up from the other thing you said a while back. So when we're looking at adults, like you say, often gender-based violence, I believe, I might be wrong with this, but I believe 90% of victims are female in adults, and
Yes.
about 10% are male. So it's not exclusively violence perpetrated from men towards women, but vast majority is. But then you mentioned when it comes to children, we see quite a different picture.
Yeah.
And is it still mainly sort of perpetrated towards girls, or is it boys, or
So
mix?
So with children, it's very different. So if it's part of a sexual crime, then it's mostly girls again. So, for example, we see a group of where there are teenagers, young women raped or sexually assaulted, and in that group, that it is much more women than men. But in the younger children, where this is more where there's the sexual abuse or sexual violence is not part of the pattern that we're seeing in these children, then there seems to be much more equal, and in fact almost slightly more boys that are affected than girls,
Right.
particularly in the young teenage years. So 10, 11, 12, it seems to be more boys than girls. So it's really interesting. There's definitely different rates depending on the age of the individual that's been affected.
And do you see, going through your door, any sort of similarities or any kind of indicators around risks, around vulnerabilities around this? Or do you see quite a broad spectrum?
I think it's broad for children. It is broad, apart from, as I said, those spikes with young girls and teenagers with rape and sexual assault. And then in the younger children, it's much more broad, except that we definitely see an increase in those who are already living in a violent household. So if there is a history of domestic violence, there is an increased risk that there is going to be strangulation as part of the physical abuse against these children. So if there is a history of domestic violence, if there's a history of strangulation against the woman in that family, then definitely there's an increase in strangulation, both against girls and boys in those families. And then there's an increase, I think, in boys who've experienced trauma. And again, that's those often who are living in those households. So boys who've experienced trauma, who have the sort of behaviour that's sometimes labelled as ADHD, or indeed boys who do have a diagnosis of ADHD, they seem to be more vulnerable for strangulation as part of either parental response to their behaviour or as part of further physical abuse.
I think the other thing that I'm thinking about is, we've talked about how challenging it can be sometimes to identify sort of risks when they're there, and the importance of listening to people, listening to children, young people, listening to adults, and trying to understand what they're saying, and that sort of initial triage of questions. But I guess the other key part of this, and you mentioned a moment ago about the importance of agencies working together, and health services working with children's services, working with the police. What would you say from your experience is really key around that sort of multi-agency collaboration, communication, when we're talking about non-fatal strangulation, if it's so difficult?
There's two things. One is language. So it is about translating what the person has said to you, using their own words, absolutely, but also putting with that a code for other professionals. This is strangulation. So absolutely, one needs to reflect the wording used by victims, but also to translate that for other professionals. So if one were to make a referral saying this person says they have had something applied to their neck, that does not hold the same level of urgency as this person says they've been strangled. And I think it is absolutely vital to have the words that the person's used, but also to, as I said, to put up that red flag to say, this is strangulation. So it's about that interpretation. And then rapidity. If somebody tells you they have been strangled, this needs to be an urgent response. There needs to be urgent referrals, and then a multi-agency response needs to be urgent. And as part of that, medicine, there needs to be medical attention. So it's really important to have that balance, that you have to use the words that the person's used, or the child or the adult has used, but also to just have that interpretation, that translation to set off the bomb that needs to happen within multi-agency services.
That's what I'm thinking, because it's like you say, you could say, oh, something happened and they grabbed him around the neck, and it doesn't, like you say, you can kind of go, oh, that's not good, but that's it. But like you say, the importance of people listening to this to understand actually how crucial that can be, to pick up on that and understand the potential ramifications of it. And like you say, the urgency then to actually deal with that situation, respond to that situation, not just, we grabbed them around the neck.
Yeah. So because grabbing round the neck is serious and can have fatal and devastating consequences. And if not immediately, later on down the line. And so absolutely that needs, and some of the most injured children I've seen has been around the clothing being tightened around the neck as part of a grab. And actually that can really cause significant injury. We had a case of a child down in Devon who was really, really significantly severely injured. And that was, again, a grab of her clothing around her neck, which caused the problem. So clothing is as dangerous. It is a ligature. It can be a ligature.
Absolutely.
So, so it is about that translation and that urgency of response for me. That's so important.
Have you got any examples of where non-fatal strangulation was identified and how it was handled, either positively handled or not so well handled?
So there's quite a well-known case who is with part of the strangulation. So there is an institute for assessment of strangulation and advice within the US, and they talk about a very young lady who's quite happy to share her details, who was a nurse, and she was strangled first time on honeymoon, and then her second time she was strangled. She 6 days later didn't feel quite right and had a bit of a sore neck, so walked into an ED. And on examination, she just had a little bit of bruising behind her ear as part of this. But because she did have a sore neck, she was scanned, and she had almost complete. I've seen her imaging actually on a training event, and she had almost complete dissection of her neck vessels, and also the bruising on the back of her ear was actually where her muscle had been pulled off the bone behind her ear.
Wow.
And she was at risk of having a stroke at any minute, and luckily she had appropriate prevention against stroke, and this has healed, but it takes a long time to heal. So she had nothing else apart from one small bruise behind her ear, and the images are really shocking. And then I saw a young lady, a 14-year-old girl, when I was working the SARC, the Sexual Assault Referral Centre down in Devon, who, when she came, she was whispering to me. She didn't mention anything, hadn't said anything to police. She'd given a full account to police before I saw her. She hadn't mentioned anything to police about being strangled, but she did say she was grabbed round her neck as part of this offence. And it was just very interesting that she just was whispering throughout the consultation. I thought it was just that she was really traumatised by it. It was a very violent offence. But actually, because she did also say she had a bit of a sore throat, so all she also had was a bit of a sore throat. She didn't remember all of the event. So we're coming back to those things that I've said already: memory loss, sore throat.
Absolutely.
And then just this whispering. And actually, if you got her to speak louder, then as I was examining her, I was asking her more questions. If I asked her to speak louder, she did have a hoarse voice. And when we sent her for scan, we did send her in the end to A&E for a scan, and she had a complete fracture of her hyoid bone, one of the bones in her neck.
Wow.
And I would never have picked that up from examining her neck at all. She had nothing in her neck to suggest that, but just the symptoms. She also had a bit of difficulty swallowing, people who've got a raspy or hoarse voice, people who don't remember what happened, memory loss. Sometimes people who've been strangled are really restless and combative. And actually, sometimes they're combative as the reason why they were strangled in the first place. And that carries on or is even worse. And they can be quite agitated. It can lead to PTSD. This young lady did end up having quite severe PTSD. And it can lead, if you've been strangled repeatedly and you've not told anybody about it, as can happen in children sometimes, it can lead to a reduction in school performance, a reduction in intellect, is repeatedly having no oxygen to your brain. And then fear. Fear is really paralyzing. It can really affect people, not only at the time of your strangulation, and people often don't struggle during strangulation because they're so scared. A huge proportion say, I thought I was going to die. And actually, they often don't struggle, which is really interesting. So there, not only is this risk of stroke, there's the risk of psychological trauma going forwards for the rest of your life when you've been strangled. It is, you can have problems with your vision, problems with your hearing. Often people will say, I've had ringing in my ears, or it sounds a bit bubbly, or their vision can be a bit blurred. They can hallucinate. and she had several of those, but it's only since I've learned about, and it was because of her case that I learned more about strangulation, which is why I'm so interested in it now. Those things are quite non-specific often and quite kind of are quite nebulous symptoms, but actually when you put it together with somebody that has been strangled, then that's really significant.
This isn't something that's new, as we talked about, but obviously with the change in legislation sort of really highlighting this area, is there anything that you can signpost to for other professionals or for parents to sort of better understand the subject, to understand it, to prevent it, to respond better? Are you aware of anything that's out there?
Yeah, so the Institute for Addressing Strangulation in the US, and they for a long time have provided lots of training and education, and there is now a UK branch as well. So if you look online at the Institute for Addressing Strangulation, and we can put a link to it at the end of this podcast, they run regular training events. They're online. Sometimes they run from America, sometimes they run from the UK. They are, I can't tell you how universally fascinating they are. They're multi-agency training. They have lots of professionals from lots of different agencies, not just me, but burbling on today. But it's fascinating. They have psychologists and police officers and all sorts of people. So their training is, I can't recommend it highly enough. That they do a 1 day, a 2 day, and a half day sessions, but they also have lots of resources as well. And what's really helpful for your agency, if you want to think about how to pick up signs and symptoms, they have really good cartoon drawing of a child and an adult with the symptoms and signs on them of strangulation, and actually it really helps to focus the mind on what the person may have and what you should be looking for. And I've certainly done some training with the EDT for Children's Social Care, and they have one of these pictures up on their wall. So it really helps to just think about that. It helps you to focus on what to look for and what to ask about when you come across somebody who's been strangled.
Lou, thank you so much for that. I think that's been so insightful, just understanding it better. Because like you say, I think quite often there's a habit of just kind of dismissing things, of saying, well, it was just this. But actually the importance of it, like you say, not just the immediate risk, which obviously there is, but also that greater risk around further abuse or death. Then we've got the medical risks there, which could be really, really significant, but also that longer term impact. And so the importance of people listening to this and understanding it better as a subject and knowing how to respond to it better and quickly has been absolutely key. And so good to hear your kind of insight into it all. Is there anything locally you can signpost to, or any sort of local guidance or anything else?
So we're currently developing guidance. So watch this space; it'll be there soon.
Perfect. Lou, thank you so much for your time today. Really appreciate it. It's been fascinating talking about this.
That's great. Thank you very much for having me. And people can also, of course, always contact me if they've got further questions.
If listening to Lou has fascinated you as much as it has me, and you did want to get in contact with her, you'll find her email address in the description for this episode. As always, if you'd like to find out more details on the topics discussed in today's episode, please go to the SSCP website at somersetsafeguardingchildren.org.uk or by following any of the links in this episode's description. If you enjoy listening to the P-Pod, we would really appreciate it if you took that time to follow or subscribe to us on your chosen platform, or even better, leave a review to let others know about it, and to make sure you let your colleagues know about this podcast and encourage them to join us here as well. It really does help to spread the word. If you have any questions or comments arising from today's episode, or would like to be involved in future episodes, we would love you to get in touch with us at thepod@somerset.gov.uk. Once again, I'd like to give a huge thank you to my guest today, Dr. Louise.Newbury, named Doctor for Child Safeguarding for Somerset Foundation Trust. And as always, I'd like to thank you for listening. My name is Steve Maccabee, and I'm the Training Manager for the Somerset Safeguarding Children Partnership. And I look forward to you joining us again next time at the P-Pod.
Let's work together to help keep children safe.